We are beginning. So I have been reminded, I did not formally announce, I didn't tell anybody we weren't going to have class on Wednesday, did I? I mean, in micro, I did this morning. I thought I sent everybody an email. I will not be on campus Wednesday, or for you folks in the lab, Thursday morning. I think I told the lab that was there. So I won't be back on campus till Friday. And then, but all next week I'll be, that's the last time I won't be here until the semester ends effectively, with rare exceptions. So on that note, I will do a recording for both, one recording for both A and P sections. Good chance I might get to it tomorrow. Don't know. We'll see how things go. That's the announcement at hand. So I don't want to see your bright smiling face. You want to sit here for an hour, take it easy, be my guest. Not that I see anybody jumping at that opportunity. Okay. So let's begin. I want to pick up where I kind of want to start again at the small intestine. Try to work get through the rest of the digestive system. I did not upload the urinary PowerPoint. Okay, yeah, I got it. The service people are coming to the house for the heating system tomorrow. Oh, thank you for reminding me. Just what I needed to know. Oh, life is difficult. So let's begin. So really, the small intestine is probably the most interesting piece, just to review it so you understand all these things that make it within a matter of 8 feet, basically finish digestion and absorption. Okay, pyloric sphincter, 3-quart, again, anatomically, duodenum to begin, small, about 10 inches, C-shaped, common bile duct is there, okay? Really important, retroperitoneal, which means tacked to the back wall for stability. The jejunum, about 8 feet, and then the ileum, I-L-E-U-M, which that's to distinguish it from the bone, the ileum, is the remaining 12 feet or so. So roughly 21 feet of small intestine. Basically all the same, but we get most of the work done within that first 6 to 8 feet of small intestine. And yeah, I mean, think of how many feet that you have to basically put in, anatomically speaking, so it fills a lot of the abdominal cavity, the chyme, the secretions, completes digestion. This is principally chemical digestion. There's not a lot of movement. And all of the absorption and what's ever left sends it to the large intestine, basically to excrete and make some final changes that are there. This just reviews it. Okay, again, the contents are very, very well organized by the mesentery. They naturally, as you remember me talking to you about, that fall back into place. They are there. There's a nice piece of fatty covering called the greater omentum, as you see in some of the illustrations. That was basically like an apron that covers it from preparing to here. And this is it. Basically, it's not as distinguishable. The large intestine has these anatomical features that you should be familiar with, but everything here is basically the same. Here's that omentum. You can see that there's a lot. I mean, this is all small intestine, more or less. The vast majority of that. That's there. The big deal are the adaptations for surface area. Okay, so the first one of these has to do with something, and you'll see it, these plica circularis or circular folds. So the material, the chyme doesn't just shoot through the tube like water running through a hose. It circles round and round and round. So you have a tremendous amount of surface area just from that adaptation. You sort of spiral, and sort of like almost like a spiral effect that's there. Every square, almost millimeter, certainly centimeter, is covered with these villi. These little, and villi means fingers. They're a millimeter tall, which is but like little nubs. And those little nubs, relatively speaking to the base, are quite finger-like projections. And so they increase the surface area, and they're covered with, all over that entire little finger, are completely covered with simple columnar cells with microvilli, increasing the surface area even more. There's this immense amount of surface area within each of those fingers. And I'll show you some other illustrations. This thing we call a lacteal, which is a lymphatic capillary surrounded by a regular capillary bed. So the lacteal basically deals with fats and heavier substances. Unfortunately, sometimes microorganisms fit in there as well. And everything is dissolvable vis-a-vis in plasma. Okay, most of the dissolved material that's been absorbed, whether they're amino acids or whether they're glucose or something along those lines, goes into the effectively the regular capillary, the blood vessel part of it that are there. And adjacent to it, additional indentations that are quite deep. And again, these are the most reproductive of all the tissues that we have in the gut, these intestinal crypts, which are really just another name for intestinal glands. Remember, pits in the stomach, crypts here, fancy name, crypts of Lieberkühn, very, very famous name that's associated with it. And it's a really good illustration. So, I mean, there's an immense amount of surface area because every one of these cells that surround it are filled with microvilli. I mean, just like this amazing brush border. And there's a lot of what we call brush border enzymes there. They finalize the absorptive process. They take those short chains of amino acids from all the proteins and break them down into single amino acids that we absorb. All the lactose, all the fructose, I beg your pardon, all the sucrose, all the maltose that we ingest with our carbohydrates, broken down there effectively into glucose or similar substances, to monosaccharides, you name it. That's how they absorb things. And they're either going into this relatively substantial lymphatic capillary, famously the lacteal, or into the capillary bed that surrounds it. And you get an idea of the surface area just from looking around these individual areas. Here's a particular villus. You can see there's the lumen or the cavity that the chyme is traveling down. Here are all the microvilli. Here's a really good illustration of a bigger part in a micrograph. This is just more and more surface area. And the enzymes, so we call it a brush border, and hence the name brush border enzymes, that kind of stuff that we see there. Very interesting. Simple columnar cells are the hallmark cell of this. Again, here are these circular folds. I'll show you another illustration with it in a sec that are there. So the mucus plays a role. Okay, there's different kinds of glands. And see the alkaline, remember it's all pH. We've got to neutralize all that acidity. This is all about alkaline. So it's elegant set of pH control. We'll get a little bit of that when we get into repro. And that's why I have to get urinary in. I know, to be very honest with you with regard to urinary, I'll review the anatomy and I'm not going to go crazy with the physiology. The urinary physiology is probably as hard as any there is that we study. We just had an MCAT class with a couple of students who are over at Duquesne heading into their osteopathic medical school. I mean, we were talking about the physiology of repro and renal. Oh boy, that's the part. Moving on. So here we have the intestinal glands. It's a liquid fluid type of there. It's not so much mucousy. It's alkaline. There's a lot of dissolved enzymes in there. Remember, these enzymes, okay, that are in the microvilli alone, these are just some of the ones breaking down the peptides into amino acids, as I said. All of these, again, if you don't have the lactase, now you have somebody who's lactose intolerant. Various lipases breaking these down into fatty acids. The glycerol goes into the bloodstream. Fatty acids, there's a limited capability, depending on how much they can be broken down. The secretin and cholecystokinin, those are the two big, effectively chemical messengers that play a role. And again, it's all about, as it shoots through their stretch receptors, when they're stretched, it releases and encourages the release of all of these substances. It kind of takes care of business itself. We don't have to worry about it unless something goes wrong. So if you're lactose intolerant, you know what happens when something goes wrong. Okay? If you have, like I did, ulcer disease, you know what happens if something. So it works. It's convenient to forget about it when it works well. Lots of antimicrobial substances and a very good summary this year. So we're not going to go into learning all of these names. So like with my advanced physiology class, we just finished this unit. And I mean, we're talking more about the specifics with the enzymes and the actions of enterokinase, et cetera, those types of things. So it's a matter of degree. So in response to stretch receptors, anything that's in there, gastric juice, because it's acidic, is an irritant. Okay. It stimulates goblet cells. They make the mucus that's protective in nature as well as lubricating. Again, the fact that it's stretched immediately triggers the segmentation of the peristalsis. It's just a wonderful process that we don't even take the trouble to think about most of the time unless something goes wrong. Okay. Villi, about surface area. The small intestine, that's the critical piece. Thankfully, we have a lot of it. If some has to be removed for whatever reason, that's there. So absorption is so effective that very little absorbable material reaches the organ's distal end. It's done. Okay. Carbs, okay. It starts with salivary, amylase, and then we don't touch the carbs till we get into the pancreas. And we get into the small intestine. That's when the pancreatic amylase finally completes the breakdown of starch and glycogen into the whatever the constituent disaccharides are. And at that point, the brush border enzymes take it down to monosaccharides, and in they go. We're not going to get into what I did with my other, the intricacies of the process of absorption. Just as an aside, the key player in this is your old friend sodium. Remember, you're going to see a lot of this, and we'll allude to it even in renal. When sodium is pulled in, we call that, you might remember this, it's a long time ago from AP1, something called primary active transport. I see recognition in at least one or two sets of eyes. Ringing a bell, primary active transport. What happens, we use the flow and we bring other stuff in along with the party. It's called secondary active transport. So the sodium sets up currents that you either bring stuff in or the backwash can push stuff out. This is where a lot of stuff comes in. So sodium is a big player in this. And again, that's more for my advanced class, but I want you to understand this is sort of why I try to lay the foundation and why it plays so important. That's there. Proteins. We didn't touch proteins till they got in the stomach with pepsin. There's a ton of these proteases that are secreted, as you might remember, in an active form. They're activated, particularly in the alkaline environment, and eventually the amino acids are brought in by the blood vessels. That's what we absorb, amino acids. Again, I have no objection to you taking protein powders. Don't expect that we don't absorb the proteins. Those are just building blocks. So protein powders for somebody who wants to go and work out and build muscle are fine, but it's not direct. Okay. And that's a big problem. People have to understand when you're doing that type of thing, if you have a very high protein diet, for you young, healthy individuals, drink a lot of water. Because you're going to create a way, you have to get rid of that excess nitrogen. That's where your kidneys come in. Drink water. And they're just showing you some of the chemistry, which you don't have to know. You might remember this because I showed this to you in AP1. Okay. Fats, the bile salts, enzymes, glycerol, and fatty acids. It depends. They're either absorbed into the blood or lymphatic capillaries, depends. Okay. There's larger amounts, and again, you don't have to go into this. Depending on what kinds of things that are there, okay, they might form these things called chylomicrons, okay, and it sort of depends on the combination of fats. Again, these are not big things for you to know now. When you ingest a particularly fatty meal, it takes a while for that to work its way through the bloodstream, and there inherently can be problems with that. Okay. If you understand that temporarily people who really eat a ton of really problematic fats will form a bunch of these, and they are a problem. These are what we call very low density lipoproteins, the way they're traveling in. If you have blood vessel disease, they can get stuck. Depending on the fats, it can be very pro-inflammatory. Just saw a very big article about that. I forget in what medical or scientific outlet. To understand the difference between omega-3s and omega-6s, when you're looking at things, dietary, young people don't think about it as much unless there's a strong family history. Omega-3s are good, omega-6s are bad. Leave it that way. encouraging you to eat salmon. I have a great recipe if you're interested for a salmon gremolata. No takers, huh? Classic gremolata is lemon zest, fresh parsley, and fresh garlic all chopped together. Genius. Brilliant. Guys, so they're showing us the way some of this stuff gets through. Not a big deal. Not a big deal. Peristalsis and segmentation, parasympathetic impulses. Okay. This is a lot of times, this is what happens when somebody ingests something. Let's say they're lactose intolerant. Just for an instance, sometimes you put too much in there, it'll over distend it, and the peristalsis will become irregular and push a lot into the large intestines like an overload that triggers it. This kind of peristaltic rush could be mimicked by something like lactose intolerant, when someone inadvertently gets a milk-containing thing, or if you lose all sensibilities and decide that ice cream is the order of the day. It's okay. And then the end point is the ileocecal sphincter. That's the end of the small intestine. A couple of quick illustrations. Really didn't take a lot of time doing it. These are what some of the modifications look like. This is the circular folds. You see how they'll spiral around. You have the layers, but this is all surface area. These are little, maybe at the most, maybe a centimeter deep, and they're covered in these little nubs that are everywhere, the villi. So if you could imagine passing an imaginary hand or finger, you feel all these little bumpy things that were there. And that's all surface area. And as you go further into it, you get here. So here are the individual little nubs, and then there you can see again the brush border. Here you can see the crypt. So the structural modifications is what it looks like realistically. You don't see the crypt per se, but you get an idea of what it is. And if you can magnify that little fuzzy border is very distinctive sometimes, not necessarily in that. Here's the illustration for that. You can see all the mucus that's there. And again, tiny enzymes are facilitating. All of these are areas where materials could be entered. The fancy name for those lining cells are called enterocytes. When we really use the term enteric, we're really pointing at the small intestine more than almost anywhere else. So that's real. I think I hope that's useful to you. Here's the little nugget again that we see here. This is chemotherapy targets rapidly dividing cells. That's the negative side effect, the GI tract. This is the area. Number one area where we see that problem. Okay. Good to go there. Move it. Clogged ears at all. The large intestine, sometimes called the colon, frequently called the colon, about 5 feet long. It is basically surrounds on an outer perimeter in a vertical plane, starting at the entranceway, which is the only segment that really has a name per se, individual segment. It's called the cecum. So the ileocecal valve, and most notably, what projects off the cecum? The vermiform appendix. That's right, your appendix. So the diameter is greater than that of the small intestine for sure. Maybe probably about maybe 2.5 times larger. We're talking about something that's about, I would dare say maybe a couple of inches, depending on the diameter. Okay, the distal end opens to the outside body through the anus, so it ends where we get to the exterior. Very little processing goes on. The water it absorbs, if there's too much water, it absorbs it. If there's not enough water, it doesn't absorb it, because that's the difference between something that's overly dry versus overly wet. Think of the difference between constipation and diarrhea. Yes, some electrolytes come along for the party. That's about it. There's a little bit of certain vitamins can also be absorbed that way, but they're already absorbed earlier. We see some clotting factors, some vitamin K related substances, some B vitamin related substances that are absorbed there. That's about it. And basically it's non-essential, but obviously very, very useful. It starts with the cecum. The first of these let's see if I have the illustration here. I'll show you. Each one of these segments is called a haustrum. Haustrum. The plural is haustra. And like bacteria, bacterium would be the individual, for instance. That's there. Here you can see the appendix. That's why with appendicitis, it sort of points centrally. The appendix has an immunological function. It's a storehouse for a lot of the bacteria to what we call reseed the intestine. If somebody has colitis or food poisoning, basically you have to almost reestablish the gut bacteria that are so important for digestive balance, so to speak, and particularly in the colon. And we think that that's really the major role of the intestine. Good news, but it's twisty and stuff can get stuck. So even though we'd like to keep it in, sometimes you don't have an option with regard to that. And the fact that it points like towards your umbilicus is why you get umbilical pain. It's frequently associated. We call it, and you'll learn about this when you learn about physical, doing a physical exam or be able to, to look at that type of thing, which many of you, I think that's next term for a lot of the nursing. It's called rebound tenderness. You'll be pressing, you go, does that hurt? Oh gosh, that hurts. Try it, and then you boom, let go. And all of a sudden the patient wants to deck you. That's rebound tenderness. Always have to do that step farther away. This may hurt a little bit more. Always warn them. People, if you're going into clinical fields, you should be noting this stuff. These are little helpers. Now, you'll look good if you know what rebound tenderness is. Because what you're happening is sort of think of the peritoneum being pushed in and then stretched out again. Little sensors in there going, ow, what the are you doing to me? I'm telling you this for my health. I already passed the test. This, if you didn't get this in anatomy, this is a series of like 3 bands of smooth muscle that they thought was a tendon, looked like a tendon. They call it tinea coli, the tendon of the colon. That's another one of the landmarks. And the last one, these are called epiploic appendages, little fatty droplets. They look like little teardrop shapes. Nobody knows what the heck they're there for. So haustra or haustrum, tinea coli, epiploic appendages, important to remember. And so you have the flexures at the one under the liver, known as the right hepatic flexure, or the one under the spleen, the left or splenic flexure. It's tacked down. Everything else, basically, those are called retroperitoneal. The rest of this moves around very, very freely. That's there. And then this leads into what the sigmoid, which has an S curve, and that sort of goes centrally in your abdomen and then leads into the rectum at the end, effectively the end. And then the transition from simple columnar, still here, to stratified squamous non-keratinizing, because now the abrasive aspect of the feces plays a significant role. Here you can see, get an idea of what it looks like. These canals are there. The problem with this is with people who are with irritation or problems, and a lot of people there's inherent weakness where hemorrhoids form. You see, for many of you, if you're going to clinical fields, you'll see hemorrhoids in certain individuals. Pregnancy, we see a lot of hemorrhoids. Same 4 layers. Okay, do not have the villi or the plica circularis. They have the tinea coli. They have the haustra and those epiploic appendages I told you about. Doesn't play a role in digestion. Again, some mucus. The only significant secretion, 90% of the water that goes in, and think of the water going in there just to get things moving. Intestinal flora, again, cellulose, BK, B12, thymine, which by the way is B1, riboflavin is B2. Did you guys get that nutrition? See, good names to know. See, when you get test questions like that, they're not going to always say, oh, thymine is B1, riboflavin is B2. So if you see the term flavin, which means yellow, okay, all of a sudden in the back of your mind, ding, 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 I wonder if this is a vitamin question. So sometimes you're stuck for an answer, like on an NCLEX, it's like, oh, this is plausible. Little things like that. Just had a very big discussion with my colleague. We do the MCAT students. The biggest fault even our pre-med students have, and they're wonderful, is their test-taking ability. And frankly, I see the same problem with many of you. You study, you do the work, your test performance doesn't always reflect it. not being mean. I think it's more test taking skills than anything else. I'm not talking about the open book type of stuff. I'm talking about the hard, a la the final. What it'll be like is test taking skills are something that's an acquired skill. Some people are just lucky. They've got it. So all of that type of stuff, cellulose, we don't break. We break it down partially. That's the undigestible fibers that are there. Yeah, gas comes from it. There's different things that release it. So we all produce a certain amount, certain foods more so than others. Not a big deal that are there. Again, peristaltic waves, X amount of times. I don't get too caught up in how many times a day or any of that, or what's in the feces. People misunderstand it. Okay, it's not. It's mostly water. Okay, understand that. People think it's all undigested food. You eat more, you'll go more. No, about one more, probably about half or more of it is water. The rest is about equally undigested food, and all those cells that are replaced, the billions of cells daily, they've got to go somewhere. This is how they go. Trust me. The first thing when I had a major abdominal surgery, the first time, they wouldn't take my nasogastric tube out for 7 days until I had a bowel movement. And they also wouldn't feed me. First thing I said to the resident, to the surgeon, I said, how do you expect me to go if I don't have something to eat? And he goes, hey, you're 2/3 there. You've got water and you've got cells. And sure enough, worked. So a lot of different things. This is a big problem. During aging, the walls weaken. The vast majority of people over, I would dare say, over 70 years old have some, it's like a bubble in a tire. The wall weakens to some extent. Some of the membrane, the mucosa pouches out. It can become inflamed. Inflammatory bowel disease is a very, I don't want to say non-specific. These are the worst types, ulcerative colitis and Crohn's disease. You do not want these. And obviously notice that number. That's why after a certain age, they're advertising it all over. Okay, all these tests that you can get done. They make sense. Basically, you're taking a stool sample and a small amount of it. They mix it, you send it away. They'll tell you if it tests positive for anything that's there. And depending on the test, believe me, once you reach, I know none of it seems far away for most of you. Once you hit the magic 40, all this stuff becomes, it becomes things you're much more familiar with. Do not, you got to do that. So here, well, this is the bad stuff. Tooth enamel thins, gums recede, teeth problems, less efficiency, slower peristalsis, less secretions, more problems, constipation, diarrhea. Okay, all these things, lactose intolerance. I cannot tell you how many people have become lactose intolerant or developed gluten allergies or developed food allergies later in life. We talked about this in the immune system. You can get an allergy anytime. You can become lactose intolerant anytime. Just the way it works. Okay. I have 2 stepsons who are, my wife's, the 2 of her 4 younger sons are the two of her 4 sons who are the younger ones, both got this in adulthood. Severe food related problems. Severe. Oh, that's that. I think we're good there. I don't think there's anything else physiologically to cover in this. If I do, I will cover it in the review. Yay! That's right. We're starting kidney. So talk to me. Kidney was one of the things that did you sort of self-cover that, as it were?
Yeah, and he lectured.
Pardon me?
He lectured on it.
Okay, so you did the anatomy part of it. You didn't do like countercurrent multiplier, countercurrent exchanger, juxtaglomerular apparatus?
Yeah.
A little bit.
Tubes and
Renin angiotensin aldosterone mechanism.
briefly that he never looked at.
Gotcha. Guess what? Now you get Stein's view on this. It's okay. You don't have to thank me. Oh, Allie said she couldn't be here. I don't think she likes me.
That's what you think.
Yeah, I don't think she likes me. It's all right. I can take the hit. Most of you are saying, let me see how many more lectures. I don't have one Wednesday. I've got Friday, and I've got next week. And whether or not we have one on the fall on the last Monday before class, hopefully not. Then I'm done with that person. I was going to say SOB, but that would have been impolite. I could have said POS. It's okay. I told the micro people. My wife is so mad at me from wearing stained shirts. I have to. She has to examine my clothes to make sure I don't go out looking like a bum. It's okay. Kidneys. Let me give you job one for the kidney. Nitrogenous waste removal. The biggest single thing that the kidneys do is to get rid of nitrogen. You heard me about the amino acids. You heard me pushing the water. Understand, everybody, that we have a very limited ability to deal with nitrogenous wastes. Okay? Nitrogen becomes a poison. All the amino acids, okay? Basically, what happens is that we eat in proteins. The first thing we do is we take off the amino group. Remember, the amino group was an NH2 group. As soon as that NH2 group goes into the liquid, which surrounds everything, into water or plasma, it becomes NH3. That, everybody, is ammonia. Ammonia is a highly, highly toxic compound. Yet magic occurs because of the way we are designed. Okay? It's brilliant. We take this. We have carbon dioxide, right? And what we do is we take, you don't have to know the chemistry, we take two ammonia groups, and what comes out of that is this magical compound. It's a carbon double bonded to an oxygen and an NH2 group on either side. It's called urea. It's about 100 times less toxic. That's what the liver does for you. So your liver does that. We're just talking about digestive. It detoxifies, and it's more water soluble. That's why it's less toxic, and we excrete it. Hence the name urine. There's another one that we make from all the RNA and DNA, all the nucleic acids that we have. We're constantly breaking down cells and things like that. It's called uric acid. It comes from purines. That's the A's and the G's. Adenine and guanine, they're purines, the big UR. It's where uric acid. We have to get rid of the vast amount of that stuff. That's nitrogenous waste. So that excreting metabolic waste as well as toxins and drugs. The liver does the job of getting them water soluble. The kidney has to get rid of them. And in the process, regulating water volume, basically making we have enough fluid in or enough fluid going out. Ion concentration. So it's very busy. So all those wonderful sodium and potassium and chloride and bicarbonate levels. And because of that means long-term acid-base balance. And this is incorrect. I loaded this PowerPoint because I forgot to load the other one from your textbook. And they made a PowerPoint boo-boo here. Erythropoietin regulates red blood cell production. Remember, it stimulates bone marrow. And the renin is the one that plays a role in the mechanism we'll go over yet again, the renin, angiotensin, aldosterone mechanism. Okay? So make a note of that, please, because that's really important. The kidneys are busy. Good news. We have two kidneys. Okay? Not only don't we need two, we only need about a quarter of one. If we have 1/8 our kidney function, we won't even notice a problem. So it's that recurrent thing we see with digestion, recurrent thing we see with circulation, the recurrent thing we see with breathing. All of a sudden, somebody who has kidney disease, they go to the doctor after after a kidney infection or some type of blood pressure problem, and the doctor goes, "I have bad news. You're going to have to be on dialysis for the rest of your life because now you need a kidney transplant, or you wouldn't be able to survive a kidney transplant." You have You have to understand, once that function of both kidneys falls, or one kidney falls under 25%, or both kidneys falls under 12.5%, all of a sudden you went from I can go versus I have to be on dialysis. That's the good news and bad news of the human body. We have so many redundant or backup systems that when they finally go on you, then all of a sudden your life has changed. So everybody, you'll see that when you get a regular blood test, we estimate. You'll see this every time you get what's called a complete metabolic panel. If you're going to a clinical field, you'll have people, you'll see a ton of these, and it will say estimated GFR, glomerular filtration rate. They give you, that's a quick snapshot based on blood tests, how your kidney is doing. As long as it says it's doing good, that's good. If it doesn't, someone's going to want to know the reason why. Activating vitamin D, very important. Without vitamin D, not going very far because you can't absorb calcium as much as you should. And yeah, if we need glucose in an emergency, yes.
Is there at any point, maybe not as far as kidney disease, but where gaining back your function?
No, probably not. Once they're shot, they're shot. They really are. I mean, it's what happens is deposits in the kidney occur. Some of them are autoimmune, some of them for damage from a variety of factors that are in there. I suppose, short answer, I don't know. But from what I know, I would think not. Many, many years ago, my first wife, when she left the emergency room, it's tough to be, many of you guys may find this out, depending. If you have, try not to get into a relationship where you work. But when your husband's a doctor at the hospital and you're a nurse at the hospital, it's not easy. Or it doesn't matter whether I'm talking about my relationship with my first wife. That creates some issues. It was better off. She left and went work dialysis for a year, which I'm sure has changed at that time. So where our focus is the kidneys. I'll give you a little bit about that. We used to say upper and lower tract. Now we don't say that. The kidney is where it all shakes. The ureters are basically a conveyance for urine. The bladder is a temporary storage area. You'll have a question on that because this guy had bladder cancer. And urethra, significant because it's the exit point. There's not a lot of function goes there. Anything that functionally happens there is probably bad if we have to talk about it. Okay? That's supposed to work. Anatomically, I'm sure you got this right. It's lower because the liver sits on it. The size difference is negligible. Here's the big thing right there. Notice the adrenal artery. You can't be, notice the inferior phrenic artery. Okay. Notice the inferior mesenteric artery. Notice the renal artery. This is drawn to scale. The kidney is a high pressure filter, period. It relies on pressure. The blood vessels tell you, anatomy tells you all you need to know. In order for it to filter appropriately, you need blood pressure. If your blood pressure drops, okay, at that point, we have something called shock. Your kidneys inevitably stop working. The kidneys have one response to adversity. Infection, they stop. Not enough blood flow, they stop. Lack of blood pressure, they stop. Kidneys are bad like that. They stop. They shut down. There's a little kid that, that's the kidney. Take it from somebody whose kidneys have shut down and ended up in intensive care. It ain't fun. I know. Back to his checkered health history. I'm so sick and tired of hearing about this. I know more about Dr. Stein's health history than my own. Sorry, I'm tired of talking about it. But it's good to show you how you can recover from these things. There's the kidney. They're kidney shaped. So we don't have to do a whole lot about this. This is the entrance point. This is mostly anatomy. Yeah, they're shielded by the ribs. That's fine and dandy. Yes, there's a little bit of fat around it. Protective in nature, just like the heart. Also useful in cooking if you did not know that. Okay. Obviously, none of you are trained French chefs. Did you? Okay. Nobody cares. It's got a hard capsule. It's very much like lung on the inside. Gushy. Blood. All it is blood vessels and membranes. That's another area where infection can get in. It's got a hard capsule around it. This is retroperitoneal. They're important. They're protected. They're behind. Pardon me, I beg your pardon. My ears are so clogged, I don't know why today. So all of this is true. You can read through this. This is something you look for when someone's been in an auto accident. One of the reasons we get a urinalysis in an emergency situation, or when we insert a catheter, we look right away to see if there's blood in the urine. I mean, it could be innocent enough, but if it's there, it has to be evaluated as to why. It'd be a big problem. It's like any other organ these days. It has an outer area we call the cortex. That's where all the filtration occurs. And it has an inner area called the medulla, as all inner areas are formed. And by and large, other than being a passageway for blood vessels, that's where the urine gets concentrated. Okay? Filtration and a lot of processing of the urine occurs in the cortex. When we talk about concentrating the urine, retaining water, which we must do, okay, it is in something called the renal pyramids, which you will see. They're interesting pyramids because their tip points centrally toward the inside, the base is toward the outside. And so it's easier for me to show it to you because this is anatomy stuff. And this is what it looks like for real. As you can see, it's an actual kidney. And so here is a very good schematic. So the cortex, very granular in appearance. That's where the functional unit of the kidney is called the glomerulus. Something called the nephron. There's two different types. The glomerulus is where filtration occurs. These are called columns. In these columns are where blood vessels come up consistently through the columns. The pyramidal structure are a series of tubes that are for the express purpose of holding on to water where it's necessary, concentrating the urine, because inevitably, that's what concentrating the urine, we have to reclaim about 99% of this thing we call filtrate, as you will see going forward, that are there. And then effectively, think of the urine dripping out of the tips of each of these pyramids being collected. These are called minor calyces. It's a series of funnels. This is a little funnel that leads into a bigger funnel called a major calyx, which leads into yet a bigger funnel called the renal pelvis. And the stem of that bigger funnel is the urine. At that point, this is all right now. Once it drips out of here, it's urine. Kidney is done processing. Now it's just collecting and transporting it for excretion. This is the entry part for the wide artery and the exit part for the vein. Without getting into the infection, a quarter of your blood each minute when you're not physically active is there. A quarter. When you're asleep, the vast majority of your circulation, probably the better part, close to 50% is going to the kidney and to digestion. Okay? You don't have to know for me all of this type of stuff. I will show it to you. It's all sympathetic nervous system. This is, we only have a few minutes left. This is the renal artery divides. It divides up through each of these columns. They all have names. Once they get through the columns into the outside of the medullary area, which is this, into the cortical area. They begin to radiate off. They arch over the base of the pyramids. And then what they do is they release tiny capillaries that form into this thing called the glomerulus. This is the whole secret sauce of how kidney works. It's fascinating. It's the only place in your body where you have an arteriole entering a capillary bed and exiting as an arteriole. This is its function. We use that high pressure normally to generate a filtrate, to process blood going into a capillary. We expend energy and it goes from arterial blood to venous blood. It's the only area where we will let pressure effectively filter, just like you water pressure. When you put water into a drip coffee pot, hot water from the top, it drips through. You don't have to add any extra energy to make it drip through. Gravity takes care of it. In this case, blood pressure filters it through, so you have not used any of the oxygen as an energy source or nutrients as an energy source here. They go directly through, and then depending on what's happening, the processing, whether we're reabsorbing or processing it, that we'll learn about next time in the capillaries, or concentrating urine in the vasa recta, which we'll learn about subsequently. That's what happens there. That's the unique system that's there. So I'll leave you with that, and we'll address the nephrons starting shortly. Thank you. Have fun. Bye-bye. Stop recording.